Okay, good morning everyone. So we'll start this session. This is poster podium presentation, orbit and oculoplasty. So this is award session, as you all know, and you will have 4 minutes for presentation followed by 1 to 2 minutes of discussion. So, so I would like to invite the first speaker. If Dr. Atul Kamant is here. Dr. Atul Kaman. So who's here? Can you just tell me the second one, or what's your good name? Okay, then you can come, please. Huh? Vatsale is okay. She'll be presenting paper on evaluation of platelet-rich fibrin in contracted socket reconstruction.
Hello. Ma'am, am I audible? I can start. Yeah. Good morning. Good morning, everybody. Today I'll be presenting. Can I start? Good morning, everyone. My presentation is on evaluation of platelet-rich fibrin as a surface healing succor in reconstructed contracted sockets. So platelet-rich fibrin is a second-generation platelet concentrate which serves as a three-dimensional intrinsic structural scaffold of fibrin mesh comprising of platelets, growth factors, and circulating mesenchymal stem cells. It has anti-inflammatory, regenerative, antimicrobial, and antifibrotic properties. This flexible fibrin mesh is an
It's not
effective
working.
surface
It's
healing
not
conduit,
moving. See?
being autologous, reproducible, biocompatible, and non-immunogenic. It is a prospective interventional study design with a sample size of 24. The recruited cases were moderate to severe contracted socket, grade 2 and above in Gopal Krishna classification in need for surface augmentation. 14 patients underwent mucous membrane grafting, which were considered as controls, and 10 patients underwent platelet-rich fibrin implantation. The wound assessment was done at 1 week, 1 month, and 3 months using the wound evaluation scale. How do we prepare the platelet-rich fibrin? We drew autologous whole venous blood, and thereafter it was taken in an activator-free or coagulant-free vacutainer. It was centrifuged at 3000 RPM for 10 minutes under strict asepsis condition. The polymerized fibrin clot was drained to obtain the PRF membrane. We followed up based on the wound evaluation scale at week 1, month 1, and 3 months. And as we can see, we saw that the whole WES score 6 was obtained in PRF patients at 1 month itself. And in case of MMG, it took 3 months to achieve the WES score. The complications which were encountered in the mucous membrane graft subset were graft contracture in 3 out of 14 patients, whereas no such complication was seen in the PRF group. So, current concepts of the use of PRF finds its way in oral surgery, ENT, plastics, and orthopedics. So, as a biopolymer, its role has been established in ophthalmology as an autologous biomaterial after pterygium excision, as a human-derived culture medium for expansion of limbal stem cells, as a temporary patch graft in case of severe desmatoceles, as a tool for ocular surface regeneration after glaucoma filtration surgeries, as a substitute for ILM in refractory macular holes. So PRF provides a prudent physiological three-dimensional fibrin reservoir for cytokine enmeshment, cellular migration, and sustained release of growth factors and stem cells. It is autologous, economical, and easy to synthesize. It obviates the need for a donor graft site, as in case of a mucous membrane. And to the best of our knowledge, it's the first study that showcases the utility of PRF membrane for surface augmentation and socket reconstruction. And it elucidates that in addition to facilitating local wound healing, PRF is an excellent alternative to mucous membrane in management of contracted sockets. These are my references. Thank you.
Yeah, Dr. Valsalia, good presentation. So one doubt, how is it different from autologous serum eye drops?
Ma'am, the preparation is where it varies. So in case of autologous serum drops, it is more as platelet-rich plasma, not platelet-rich fibrin. So how the process differs is that in case of autologous serum drops, we first take the blood sample in a clot activator vacutainer, we centrifuge it, it separates into three, and the buffy coat and the acellular plasma is again recentrifuged in second. Thereafter, for the autologous serum drops for the platelet activation, we have to add bovine thrombin and calcium chloride. So that entire process is obviated when we are creating a platelet-rich fibrin membrane. So here we take it in a clot activator free vacutainer and just a single centrifuge. By the centrifugation essentially slows down the polymerization process of clot formation. So that is how essentially in the process it varies. So we are not using any external agent for the polymerization. It happens on its own and we have no clot activator involved in this case.
Will you do any screening procedures for that particular patients? Any like a blood screening, basic screening like HIV, HBsAg you do?
Sir, it is autologous, so essentially
Is it necessary? Does it have any impact on the patient's that survival of the graft?
Sir, essentially we would not do it in a case of an immunocompromised patient per se, because we are trying to localize the growth factors as well as the inflammatory mediators. So, but otherwise it doesn't make any impact as such speaking, because it is autologous in nature.
So in what way you feel that it really helped in your patients, and what was this WES score?
So ma'am, wound
you should
evaluation score has
Wound?
wound evaluation score.
So is it a standard way of evaluating?
It is a standard way for epithelium, for any epithelial wound healing, and it has 6 parameters. The parameters are step-off borders, contour irregularities, edge inversion, we have scar width, the inflammation along the scar, and the overall cosmesis. So it's an all or none score, that is 0 and 1. So, and based on that, out of 6 we graded it.
And this is given by whom?
Ma'am, this is essentially described for the first time in 1857. It's for the skin. Essentially, it's for skin epithelium, but it's not been described in orbit essentially so far.
And you said in 3 months it's there in MMG group. What you said?
So basically, the score is out of 6. So at 1 month of post-op, we found that 6 on 6 we could get in PRF patients, whereas MMG also achieved that, but in 3 months. It achieved 6 on 6 score in all patients. But
Okay.
in one.
So how you confirm the epithelialization? I'm not getting that.
Ma'am, based on the wound along the basically the suture line where we place the MMG and where we place this fibrin membrane, the healing of the suture line was graded based on this wound evaluation scale.
Acha, okay. Thank you.
Thank you.
Next you can.
I think Dr. Atul Kamath has come. I think I will. Dr. Atul Kamath will be presenting on status post-exenteration in mucormycosis, death, disability, and depression. Over to you, Atul.
Good morning, everybody. I'd like to apologize for coming slightly late for this thing. So my topic is status post-exenteration in mucormycosis, death, disability, and depression. So the aim of our study was to know the status of the patients who underwent post-exenteration after orbital mucormycosis. So as we all know, after the second wave of COVID-19, there was a outbreak of mucormycosis and especially orbital mucormycosis, following which it was most of the patients underwent some sort of orbital exenteration and some amount of ICU admissions for the same. So what we did was around 47 patients who were confirmed with orbital mucormycosis and underwent exenteration for the same were followed up for a period of over 1 year. And the cause of death, if it occurred, was noted and analyzed, and the people who survived, the patients, they all underwent Hamilton Depression Score for depression and social anxiety appearance test for their exenteration procedure. So out of the results that we found out, around 89%, that is 42 of them either expired within the first month of exenteration surgery, and the most common cause was being either the CNS extension of the mucormycosis, which was seen in around 29 patients, and the second being unrelated medical conditions like uncontrolled diabetes mellitus, which was around 13 patients. So the 6 people who survived, 2 developed moderate depression and 4 had severe depression, with the Hamilton Depression Score Test feasibility. Excuse me. And all 8 of them had severe social anxiety. So the discussion, there's only one study which says that there was significantly higher levels of anxiety and depression post-exentration of the orbit. And 3 months post-exentration was what they did on a follow-up. We did it after 1 month of the follow-up of the surgery of exentration. So conclusion, the second wave had created a lot of havoc and many developed mucormycosis, for which destructive procedures like exentration was done. Along with the high mortality following the surgery, post-surgical depression and anxiety levels were very high, and this needs to be tackled at the earliest to prevent any suicidal tendencies among them. References, thank you so much.
Thank you for that very interesting presentation. So this Hamilton score, is it a validated scoring system?
Yes, ma'am. So we took the reference from the psychiatry department, and they given us a score sheet. Based on the questionnaire, we have to tick the questions, and with that we'll get a score, and based on the grading, we can grade them into mild, moderate and severe depression, ma'am.
Okay,
it's a question of around 20 questions.
Is it available free of cost, or
yes, ma'am,
you
it's
have
available
to purchase
online.
it?
We can download it. It's available online. The questions which are available, you have to just ask them and go on ticking the questions.
You did not show the questionnaire as such. You should have shown the questionnaire, you know.
Okay.
All right. So only very few patients were left for the evaluation.
Yes, ma'am, because most of them were either very severe and were in the ICU, so they couldn't make it following the exentration. Because exentration was done usually at the end stage when we weren't able to, so the patient was very severe, and just to have a last minute thing, we used to do the exentration part. So after the exentration, most of them would go to the ICU. And those who survived were only around 7 or 8 patients in whom we could do this particular scaling. Rest of them were either too debilitated or intubated, where we couldn't take the questionnaire out of them. And most of them lost their lives because of the severity of the mucormycosis.
But this was post-exentration, no evaluation?
Yes, ma'am. So the people who survived after the exentration was also very minimal, ma'am. So hardly 7 to 8 patients.
All right.
Was the patients was given any psychiatric medications post-exentration?
The 2 or 3 patients were started on psychiatric medications. So who had severe depression were immediately started on psychiatric medications, and currently they are doing well, sir.
They're doing.
Yes,
so
sir.
you mean to say that post-exentration, the psychiatric evaluation is very important?
Very important.
Definitely,
yes.
a psychiatric patient. That's what we normally insist on, avoiding the exentration for the mucormycosis until and until it is indicated.
Yes, and most of all because of the removal of the eye, they had this social anxiety as well,
Good.
which because of which they led to
Yes, nice, fine presentation.
Thank you so much. Ma'am, it was around 50 to 70 years age group, ma'am, most of them who made it.
Yeah, good presentation. Just this scoring system was done how many days after exentration?
Post-exentration.
How many days post?
1 month, ma'am, because after they survived and they came out of the ICU is what we could do it. In the ICU we couldn't do it.
Yeah.
Because they had to see their face
Yeah,
coming out,
no,
and
they
only then.
went home and then took the depression score because no in-house hospital can grossly affect the scoring system.
After they were discharged, after 2 or 3 weeks, they were called back and then we did.
Thank you. We'll call the next. The next speaker is Dr. Dr. Samia Muji.
Next we call upon Dr. Soumya Mujib to present the case on a seamless eye opener, a case series of patients with a mild ptosis.
Good morning, everyone. Today I'll be presenting a case series of patients who underwent MMCR surgery for mild ptosis. Muller's muscle conjunctival resection is described by Putterman and us. It is a minimally invasive surgery and it is posterior lamellar surgery with a good surgical outcome and a short learning curve. So the main aim of our study is to see the outcomes of MMCR surgery in patients with mild to moderate ptosis with a good LPS action. It is a prospective type of a case series of 25 eyes of 24 patients, and they were followed up post-operatively on day 1, 1 week and 1 month. All patients with mild to moderate ptosis with good LPS action were included. Patients with severe ptosis, poor LPS action, glaucoma and conjunctival disease were excluded. Preoperative and postoperative photographs and eyelid parameters were noted, and phenylephrine test was done so as to judge the amount of Muller's muscle that has to be resected. Moving on to the surgical procedure, which was done under local anesthesia. Double eversion of the upper lid was done. Then markings were done with the help of gentian violet and calipers based on the amount that had to be resected. So first, the markings were done at the superior border of the tarsal plate and then 4 to 4.5 millimeters beyond that. Then at the distal markings, 3 traction sutures were taken, central, medial and lateral. And then the 3 traction sutures were lifted up and then the Putterman's clamp was placed. Then 60 double-armed sutures, victral sutures were taken and then they were passed in a serpentine fashion from lateral to medial and then back from medial to lateral. And then the Muller's muscle conjunctival complex was excised exactly between the Putterman's clamp and the sutures that were taken. And then the 2 sutures were externalized through the skin and tied up with or without a bolster. Coming to the results, 23 out of 25 eyes definitely did have a good, and as per how much we suspected, they had a good increase in the MRD1 and palpebral fissure height. The patients achieved an increase of MRD1 by 1.5 to 2 millimeters. 6 out of 25 patients had a negative result for phenylephrine test, and they also showed a good surgical outcome. These are 2 patients who underwent a right eye MMCR surgery, and you can see right from post-op day 1 to 1 month, there is a good lift and an aesthetically suitable outcome. 2 out of 25 patients definitely did show undercorrection, and the probable causes could be the slippage of the sutures, discontinuity of the continuous conjunctival sutures, and the malpositioning of the clamp. You can see that MMCR is a good posterior lamella scarless surgery with an aesthetically pleasing outcome, and it had minimal tissue handling. It is noteworthy to say that eyelid elevation was achieved even in the 6 patients with negative phenylephrine test, and this could be due to the shortening of the posterior lamella and the advancement of the levator muscle, Muller's muscle, and conjunctiva complex. So I hereby conclude by saying that MMCR is a seamless eye opener with no scars and minimum tissue excision. It gives a good desired lift, good eyelid contour, preserves the tarsals and meibomian glands, and irrespective of the phenylephrine test, the outcome was very good. Thank you.
Thank you. It was very interesting presentation. Is this working? So this MMCR is a known, this thing, surgical procedure, almost I must say standard of care for patients with mild ptosis. So in the category of moderate, how you also included moderate ptosis patients also?
Very few patients, ma'am, we did not, with a good LPS action, probably 2 to 3 millimeters of lift when it was required. MRD 2 and 1 we included them. Most of them had 2 millimeters.
So they also had good correction
They
that
had
way?
good correction. They had good correction. Only 2 patients had undercorrection. They also had a lift. They had an undercorrection, and both the patients were kids. So that is something we noted, and we thought probably because of the more extra activity of the muscle that children have LPS action, because it's congenital. Probably that is one thing we're going to look into, that why those 2 kids itself had undercorrection. But apart from that, all patients had a very
And
good
did you do
outcome.
suture removal in these patients? With
did not.
what suture you used?
We did not. We did not.
Acha,
We did not.
what
We
was the
just cut
suture
down.
you used?
We did double-armed 60 vicryl was used, and we
Okay.
did not pull out the sutures. And if there was a bolster, we just cut out the bolster. That's all.
Okay, so do you know why Fasenlala Servet has become less popular?
Because of the involvement of tarsals, ma'am. There's tarsal compromise, and the patients started landing up with meibomian gland dysfunction. So that is completely nullified in this case.
So, do you think it's a meibomian gland dysfunction or some other problem which patients generally developed following Fasenlala Servet surgery?
Meibomian gland, as well as when we touch the tarsal plate and excise it, it can sort of change the anatomy and the lid contour as well. The stability of the lid is compromised. And MMCR is actually a very easy procedure. It is known, but yet it is not practiced much. So So the whole point of this presentation was not to just show its benefits, but to bring it back into practice more.
And you said around 4 to 5 only conjunctiva molars was removed, no?
No, ma'am. The markings was done 4 to 5 so almost 8 millimeter to 9 millimeter the section was done.
What is the longest follow-up you ran?
The longest follow-up, so 1 month itself. After that, the patients came back only if there was an undercorrection.
How much?
Otherwise,
1 month.
we followed up post-op 1 week.
Okay.
Removed the bolster, cut out the remaining part of the suture, and then we called them 1 month later. And obviously, we instructed them then if it comes down again, please come back to us. And none of them, so the result was positive, apart from those two particular patients.
Did you confirm whether it is an ocular myasthenia? It's not an ocular myasthenia?
We did, sir. We ruled it out.
Okay.
We ruled it out.
Yeah, Dr. Samya, good presentation. How did you do phenylephrine test?
Phenylephrine test was actually done with 5% phenylephrine, ma'am, every 5 minutes for a period of 15 minutes. 5%.
So you put it for every 5 minutes.
Every 5 minutes for a period of 15 minutes, so 3 times. And then we check.
Classes that we have it after?
15 minutes, ma'am. So 3 times. 5 minutes, 5 minutes, 5 minutes. So 3 times.
So was there any relation between this correction and the phenylephrine test? Because 2 patients were undercorrected.
Yes, yes, ma'am.
So was there any relation between this phenylephrine response and the post-op outcome?
Post-op outcome, based on the phenylephrine test, we decided how much could be resected. But the patients who did not have a good phenylephrine test, probably say the patient needs a 2 millimeter elevation, but phenylephrine test showed only 1 millimeter of elevation. We still took those patients up and they achieved a good result, ma'am. So that's why 6 patients who had dissatisfactory phenylephrine tests, like not much of elevation, they also had a good outcome. And probably that is because of the conjunctiva, Muller's and levator complex, posterior lamellar elevation. That's what thank you.
Because some others are presenting, yeah. You are representing Dr. Vibhas Singh? Yeah. Your name, please? Yeah. The next paper is cystic lesions in the orbit, clinical radiological presentation and treatment outcome. Your good name, please?
Ma'am, Shivangi Singh.
Shivani.
Good morning, everyone. I'll be presenting on behalf of Dr. Vibhas Singh. So I'll be
On behalf
Sorry.
of means?
Co-author.
I'm one of the co-author.
No, the presenting author. You are.
So I'll be presenting on the topic cystic lesion in the orbit, clinical radiological presentation and treatment outcome. It's not moving. Starting with the introduction, spectrum of disease occurring in the orbit is vast and are the microsome of rest of the body. Its diagnosis is a great challenge for ophthalmologists, ocular pathologists, and radiologists. Cystic lesion of the orbit are a heterogeneous group of conditions that may vary greatly in presumed cause, presentation, and pathological appearance. It accounts for 10 to 30% of non-thyroid orbital lesions. These lesions are mostly congenital and benign in nature. Aim of our study was to describe the clinical radiological presentation and treatment outcome of cystic disorder of the orbit. It was a prospective interventional case study done over a period of 3 years, and all the histologically proven cystic lesions were included in our study. Treatment included surgical excision for these cases. So, depending upon the location of the orbital cyst, the most common location was the extracorneal space, accounting from 86.67%, and out of those cases, superior nasal orbit was the most common location. And according to the histopathological type, epithelial cysts were more common as compared to the non-epithelial cyst, and among the epithelial cysts, dermoid cyst was the most common we found. Some of the rare entities that we found were the bilateral microophthalmos with the collogomatous cyst, which occurs because of the failure of closure of choroidal fissure. Then there was a case of cystic teratoma, which are rare embryonal choristoma. 1% of the orbital tumors in childhood are teratomas. 2 teratomas arise from all the 3 germ layers. Then hematic cyst, which occurs secondary to hemorrhages within the pre-existing lesion, like the lymphangiomas, or cystic hematoma, which is because of the extravasation of blood in the subperiosteal space, and which can be either spontaneous or traumatic. So for small lesions, we did not did any intervention, but for large lesions, surgical excision was required. Then mucosela, benign chronic expansile locally destructive cystic lesion of paranasal sinuses. It occurs secondary to obstruction of the normal drainage pathway of paranasal sinuses. The sinus mucosa continues to produce mucus and accumulate in the closed cavity, causing this lesion, and 90% are frontal and frontoethmoidal mucocele. So I would like to conclude that apart from aesthetic effects, orbital cysts during their growth can cause motility disturbance and optic nerve compression syndrome. Always suspect cystic disorder if a child is present with microophthalmos and displaced eyeball. Dermoid cysts are the most common congenital epithelial cysts. Mucocele are cystic disorders of paranasal sinus. Secondary affecting the orbit may lead to visual impairment. So ultrasonography, CT scan and MRI are important diagnostic modalities for these cases. Thank you so much.
That's a wonderful presentation, Dr. I think Biba.
Shivangi.
And see, the thing is that, you know, what is called sclerosing agent, any patient you tried of sclerosing agents, you told something like a small lesions.
Yes.
Did you try anything called sclerosing agent?
No, sir. We only reported the cystic lesions, sir.
And after cystic lesions removed, so you told microophthalmos, did you like, and any expanders were used here? Orbital expanders?
Explanters,
Yes.
sir.
Hmm?
No, sir.
Okay. So how many patients lost the vision in these cases?
So about 40 patients, sir. No.
Any questions?
What was the indication of, in case of bilateral microphthalmia with cyst, what was the indication of removal of the cyst?
Ma'am, if the age is less than 5 years, then we do not remove it because it will cause contracted socket. So we waited till 5 years of age till we can go for excision. Sir.
You did not use the sclerosing agent.
No.
Your inclusion criteria should have been cystic lesions on imaging rather than histopathology.
Right. Okay. Thank you.
Julie Singh is there. So the next presenter is outcome of DDCR in patients with history of failed lacunar sac surgery by Dr. Anjali Singh.
Should I start? Good morning, everyone. Thank you, AIOS, for giving me this opportunity. So we all know. Excuse me. Okay. As we all know that watering is the main presenting complaint in any plastic OPD, and external DCR is the treatment of choice. But what brings distress to both patient and surgeon is a post-op epiphora. Failure rate of endonasal DCR being slightly higher than the external DCR, which brings us to the purpose of our study, which was to evaluate outcome of repeat external DCR in terms of anatomical and functional patency in failed prior DCR and investigate causes of the failure of primary surgery. It was a retrospective, non-randomized interventional case series. Out of 270 patients who underwent DCR, 28 were included who had a history of prior DCR. So inclusion criteria was age more than 18 years, minimum 3 months of follow-up, and history of previous lacrimal sac surgery. Also the patient who consented, and all the patients with history of trauma and suspected neoplasia were excluded from the study. So a brief discussion about external DCR, starting with the meticulous sac dissection, followed by ostium formation, taking care of to maintain the standard boundaries mentioned in the literature, followed by raising the nasal mucosal flap and its taut anastomosis, because the saggy one will sag down and eventually obliterate the ostium, leading to the failure. So talking about the results, there was slight female preponderance. Epiphora was the main presenting complaint, and mean age of presentation was 48.6 years, and mean group was 41 to 50 years. Mean duration between previous surgery and recurrence of symptom was higher in external DCR, 18 months, and endonasal DCR was 10 months. Other associated conditions that could lead to epiphora that were included in our case were MGD in the highest number of patients, followed by lead laxity, punctal stenosis, and eversion. So maximum patients, 61% had history of endonasal DCR previously, followed by external DCR. Then there was a group of patients that had underwent multiple surgeries previously, like twice under endonasal DCR and once endonasal and once external DCR. What we found intraoperatively as the main cause of failure was inadequate ostium, followed by complete obliteration of sac mucosa, higher lacrimal sac opening, and fibrosed sac. What we did intraoperatively was a meticulous dissection to save as much as possible remaining nasal mucosa and sac wall, and only anterior flap was sutured to the mucosa. Silicone tube was inserted in all the case and kept in situ for 3 months, and application of mitomycin C 0.04% for 30 seconds. So at the mean follow-up of 16 months, all patients had 100% patency anatomically, and no functional epiphora was seen. All patients has cosmetically acceptable scar. So discussing this patient case report here, this was a case of failed endonasal DCR done 2 years back. When patient came to us, she has a slight bluish cystic lesion in the inferior fornix extending up to the lacrimal sac region. A CT scan was requested, and extracorneal tissue was seen at the inferior aspect of the medial canthus. Intraoperatively, that cyst was involving lacrimal sac. It was resected, and even DCR was done with 100% anatomical patency. In this case was failed endonasal DCR done 1 year back. On nasal endoscopy, there was mucosal synechia. Synechulitis was done, followed by external DCR, silicone tube, and MMC, 100% patency at 6 months. So we compared our study with the similar other studies, and what was specific in our study that we used mitomycin C and silicone tube in all our patients and not just a few specific patients, and we achieved 100% result. So it's very challenging to plan a failed DCR. However, with use of silicone tube and MMC, it gives excellent surgical outcome, and it's equally valuable in failed cases. Thank you.
So what is the most important surgical step for the best outcome in DCR surgery? If you want to prevent the failure of DCR.
Ma'am, most common
most important surgical step I am asking.
Ma'am, ostium formation.
Anything else you want to add to this? Ostium formation means what?
Like adequate size of ostium, like it should follow the standard guideline that has been mentioned in the literature, like 2 mm superior margin, 2 mm above medial canthus, inferior up to NLDO, then anterior up to the sac and bony junction, and posteriorly. So we start with pap ratio itself. Approximately 15 cross 15 mm size.
So it's both the size as well as the
Yes.
location.
Yeah.
If it's high up, then it can again create problem. And what do you call that syndrome?
Sump syndrome.
Good presentation. How did you fix your silicone tube?
Ma'am, we didn't specifically fix it. We just passed it and put multiple knots, around 10 knots, and left it there, and it was there in situ.
Fixed in the nose, or
however, it can be stitched to the nose. It can be done, yeah, but we didn't do it.
Do you use the mitomycin C, or what stage of surgery you use mitomycin C?
Sir, after anastomosis.
Okay. You want to give any flush with the mitomycin C?
Sir, 10 cc saline.
Okay, what is the role
Thrice.
of giving a mitomycin C, like an
So
irrigation?
antifibrolysis. So it as the cases were already a case of failed DCR, so there was, as I mentioned, there was fibrosed sac and lot of fibrosis intraoperatively was seen. So that was also like that also leads to the failure. So to minimize that failure and minimize further fibrosis and closure, we used it.
You have presented so many number of patients, but does any of the patient had history of trauma?
No, sir, we excluded trauma and minioblastic cases. Thank you, sir.
Any intraoperative difficulty you encountered?
Ma'am, intraoperatively, we found mostly the cause of failure was bony osteum itself. In one patient that had one failed indonasal and failed external DCR, we couldn't find there was adequate mucosa, nasal mucosa. In that patient, we sutured the flap with periosteum and periosteum and orbicularis, and it gave it was patent. Thank you.
Okay, thank you. I think I'll call upon Dr. Ruhi Jange. Yes. So I'll call upon Dr. Ruhi Jange to present on malignant solitary fibrous tumor clinical pathological profile and management outcomes.
A very good morning all. So my topic for today is malignant solitary fibrous tumors, their clinical pathological profile and management outcomes. So solitary fibrous tumors or SFTs are rare spindle cell tumors of mesenchymal origin. They were first described in pleura by Rabin and Klemperer in 1931 and later in the orbit in 1994. Traditionally, they were believed to be non-aggressive and benign in nature. Malignant SFTs are very rare and there are very few case reports noted in literature. So here we present a case series of 7 patients taken over a duration of 16 years with inclusion criteria of histopathology and immunohistochemistry confirmed cases of malignant SFTs. In our case study, there was a male preponderance with 5 male and 2 female patients and the mean age population was 45 years. Patients presented with various clinical features, with proptosis and dystopia being the most common presenting complaint. 4 patients underwent MRI scanning, which showed well-circumscribed homogeneous mass, which was isointense on T1 and hyperintense on T2. CT scan was done in 3 patients, which showed well-circumscribed homogeneous mass in 2 cases and a heterogeneous mass was noted in 1 case. Medial orbital wall erosion with ethmoid sinus involvement with cystic changes was seen in 1 case and necrosis was noted in 2 cases. Histopathology showed spindle cell tumors with vascular channels showing a staghorn pattern. Also, nuclear atypia of varying degrees was noted. The median mitotic rate was 4 per high power field. Capsular invasion was noted in 2 cases. Immunohistochemistry was positive for CD34, vimentin and STAT6. We managed our cases. 6 patients were managed by excision biopsy and 1 patient who had sinus involvement underwent lid sparing exentration under general anesthesia. The average follow-up period was 42 months. During this follow-up period, recurrence was noted in 2 cases. 1 case was managed by exentration and another underwent repeat excision biopsy with the radiotherapy of 50 gyri for enlarged neck nodes. Malignant disease or malignant SFTs arise from lower intermediate SFTs with incomplete excision, or they can be present de novo. Signs like bone erosion, sinus involvement or necrosis indicate malignancy. Immunohistochemistry is a diagnostic tool in these cases. Management can be done by complete excision of the lesions. Recurrent cases are managed by complete excision or exentration along with adjuvant radiotherapy. These are the 7 cases in literature which had comparable results to our study. There was recurrence noted in 1 case which was managed by exentration. To conclude, malignant SFTs have a male preponderance. Proptosis is the most common presenting feature. Immunohistochemistry markers of CD34 and STAT6 are diagnostic tools. Treatment of choice is complete excision of the lesion and a long-term follow-up is a must in view of recurrence. Thank you.
I think malignant solitary fibrous tumors are very rare.
Yes, ma'am.
So you did not sub-classify what exactly, because it's a very broad terminology. And there are so many tumors, named under solitary fibrous tumor. So
No,
you
ma'am.
did not
Now
mention, like,
WHO has clubbed it under one. Like,
I know, but then
yeah.
still you should see, even hemangiopericytoma is now considered
Yes, ma'am.
solitary, and even the myxomas and other,
Yes, ma'am.
fibrous tumors also. So I think sub-classification should always be there, because
Okay.
as a surgeon and otherwise also we know that each of them behaves, differently, even when we are operating. So like hemangiopericytoma tends to bleed a lot, and at everything clinically is different. This
Uh,
is histological classification,
yeah.
but you should have told us the exact, what was the diagnosis, which was missing probably in your
Okay, ma'am.
presentation, no?
Okay.
Because it's a very broad terminology.
Okay, ma'am.
And how frequently you really get solitary fibrous,
Actually, ma'am, we have
malignant
included.
solitary fibrous tumor, something which is
Very rare.
Dr. Seema Kashyap is here. She's senior professor ocular pathology. I think she can just let us know how many, like, we see in a year's malignant solitary fibrous tumor. Can you just broadly you can just.
Malignant fibrous histiocytomas are very rare. I mean, we also see very rare cases. What was the duration in which you
Ma'am,
found these
16 years this was over.
16
Yes,
years,
ma'am.
yeah.
So
Okay,
in
and
the
what was
case
the
reports also that I have taken, we have just 7 case reports over a period from 2001 to date.
I think we just have hardly 4 or 5 cases of malignant SFTs
Okay,
over the
ma'am.
last 20 years. I mean, we see the maximum number of cases in our center. What was the mitotic rate that we
Ma'am, 4 was the median mitotic rate, but like the highest was 12 to 15 that we have seen, but on an average it was 4.
for the invasion into the surrounding tissues?
Like capsular invasion was seen in 3 cases as such. Otherwise, other cases there was intact capsule was noted.
Did you see any perineural invasion that was also seen?
No, no, there was no perineural invasion.
And now it is all clubbed under one umbrella, that is SFT.
Yes, ma'am. Yes,
But
ma'am.
it's important to tell the surgeon that this is having it's very vascular tumor, it has a stack-on pattern.
Yes, ma'am.
It is like an hemangiopericytoma.
Mm-hmm.
So that will probably help the surgeon as
Okay.
How many patients had your pre-op diagnosis as SFT?
In these,
Because
actually,
when you see an orbital tumor like this, we will never go for SFT as first
definitely,
diagnosis.
yes,
So yeah,
definitely. Actually, in these, only 3 of them had SFT as the initial diagnosis,
primary diagnosis. So they were treated elsewhere or just primarily
No,
presented to
ma'am.
you?
In these, like we had patients who were treated outside also, and they presented with recurrence proptosis also. So they had come with the diagnosis of
Diagnosis.
SFT.
Okay. So their diagnosis was benign or malignant?
It was benign.
It was benign. So when you operated, it turned malignant. Okay, fine. Thanks.
Is there any role of incision biopsy here? Did you
No,
do
sir.
anything?
It has to be a complete excision biopsy only, because if, as I said, that recurrence can be because of incompletely excised masses. So that can lead to more, if SFTs itself are incompletely excised, they will lead to malignant SFT, can transform into malignant SFT.
Did you use an cryo for this complete removal?
No, sir. None of them.
All the cases you could remove completely or
Yes, ma'am.
in the first
Yes,
sitting?
ma'am.
And RT was also given?
RT
No.
was given for one patient
Okay.
with recurrence, ma'am. Thank you.
Thank you.
Vedant here? No. I think Dr. Gnanavoli, not there. Dr. Surya Narsiman.
She won't be coming.
Shall we wait for the two speakers to come?
Any presenting knowledge is not right to wait.
You have to ask local, madam. Local committee.
No.